to our Healthy It Together lunch and learn session, focusing on common childhood illnesses and conditions for children under 1 year. My name's Laura Cassidy. I'm the Network Delivery Manager for the Child Health and Wellbeing Network for the North East and North Cumbria Integrated Care Board, and I lead on the Healthy It Together website and mobile app rollout across the region. And if you could just go to the next slide, Alex, please. So just to give a bit of context around the network, we were established in 2018 and very much brought together to look at how we could test and work collaboratively with professionals from different areas of the system across the region to try and improve outcomes for children and young people. We did this by looking at priorities which were actually driven by engaging professionals, families, children and young people to look at what they would be. Our main areas of work are Children and Young People's Transformation Programme, and that covers areas like the asthma, epilepsy, diabetes, transitions. We also have 2 pilot sites around complications of excess weight for children, and that was also encompassing our integration centre work stream, which is part of the work that we do around Healthy It Together. As part of our work, we do a lot of work around tackling wider inequalities and looking at how we can improve outcomes from an inequalities lens. So you'll see there we've got things like youth mental health first aid, poverty proofing, which we have worked with Children's North East on, and that is now obviously a much bigger project and programme of work that they have been pushing out across healthcare services and settings as well across the region. Some of our more creative health initiatives is the South Tees Arts Project, which is START, which incorporates a dance initiative with family support worker model. And we also have other areas that look at things like Core 20+5, and we've developed a Core 20+5 framework toolkit that looks as it from a wider inequalities lens. Next slide.
I'm slightly worried that I haven't got all your slides, Laura. So
Yeah, I was thinking that there's a couple missing. It's fine. Just from a priorities perspective, we have a priority wheel. There is a number of priorities which you won't be kind of strange to, because actually it's a lot of things around health inequalities, long-term conditions, poverty, access. And actually as a result of COVID, we brought in family support, which is a big area that I think a lot of people are probably contributing to within the work that you do across the region. So I'm going to stop there because I think obviously this is very much a session around the focus on clinical conditions, and I'm going to hand over to Alex to introduce herself.
Thanks, Laura. So my name's Alex Vespi. I'm a consultant paediatrician at the Great North Children's Hospital, and I'm one of the clinical co-leads for the North East and North Cumbria Healthier Together. So I'm hoping in the next half an hour, 45 minutes, we'll talk about some of the common conditions in children under 1. We'll think about some of those red flags for common presentations, think about when referral is needed from the community, and probably most importantly, think about how the Healthier Together website and mobile app can support professionals and parents with this. And at the end, we'll hopefully have some time for questions. If you want to put questions in the chat, please feel free to, and I'm sure Laura will keep a little eye on it. And please feel free to ask anything and I'll answer as I can. So when we're thinking about children under 1, these are probably the areas that we think about. I get asked about the most: breathing issues, feeding issues, vomiting, crying, and staying healthy. And looking at some of the occupations in the chat, it looks like these are all things that you'll be very familiar with. So what I'm hoping to cover today is a little bit about some acute presentations, thinking about particularly things like bronchiolitis and diarrhea and vomiting, and think of some of the more longer term things, so cow's milk protein, gastroesophageal reflux and the unsettled baby, and also to think about where you can find information and how Healthier Together falls into this. Those of you that may not have seen much about the website will hopefully know a lot more by the end of it. There's a website and a mobile app, and it uses a traffic light system to think about how to risk stratify and how to support parents and professionals in that. The website has a vast array of information, and it's a national programme, and this is the North East and North Cumbria Cumbria version, but the layout and format is very similar. And the idea of that is that hopefully it provides familiarity so that as people use the website more and more, they will get used to it and know where to look and know how we think about whether or not things are serious or whether they can be managed at home. The whole website is open for professionals and for families, and so everything is very transparent. There are specific professional resources, and these come through much more in the pathways, and I will be covering both the professional information and the parent information in this session for the topics that we discuss. But I think it's important for people to understand that everything is accessible by everyone, and that's perhaps one of the strengths of this website. So the first thing we're going to think about is a little case study. So we've got a 3-month-old baby who's got 3 days of runny nose and cough with a 1-day history of worsening breathing. Mum says that they've been breathing faster than normal and they've got poor feeding and really not had very much since the morning. They're not vomiting, but they've had fewer wet nappies and they've got a temperature at home. So thinking about the topics that I suggested we were going to cover, it will be no surprise that what we think is going on with this baby is that they've probably got bronchiolitis, and believe it or not, we are still seeing it, and we're seeing this all year round. So Healthier Together does a very nice kind of explanation about bronchiolitis, and I think most people will be familiar with it. Bronchiolitis is typically seasonal, although it never really goes away, and particularly since COVID, we've probably seen bronchiolitis throughout the year. It's classically known to be caused by the virus RSV and presents with a fairly typical history of cough and coryza, runny nose, and then it lasts for a good 4 or 5 days with progressively getting worse, and then tends to plateau and then starts to get better. Information on Healthier Together will tell parents and professionals about whether or not children need to be hospitalised or whether or not they can safely be managed at home. And what I think this is quite a nice example of the first pathway. I'm sorry that it probably doesn't come out across as well on screen because it's a bit small, but you can open it in your own on your own internet if you want to have a more detailed look. And this is really what all of our pathways look like. The most important thing probably to start with is there's a section on red flags. And this alerts clinicians and professionals as to what they should be looking for to think about whether or not this is in the more serious end. It also just highlights the questions and priorities of clinical assessment. So what are the things that we need to make sure that we know the answer to in order to allow us to make an assessment of severity? And then you can see that what we have in the pathways here is similar to the traffic light system that we suggested, which is on for the parents' safety netting pages, is whether or not patients fall into green, amber or red, and what should happen for each of those. And it gives quite clear information as to where patients should be appropriately managed. And hopefully in a lot of settings, this will just kind of provide healthcare professionals with the confidence to manage patients at home, which is predominantly where the majority of children with bronchiolitis are managed, and to think about which group of patients need to be transferred higher. Bronchiolitis is something the majority of us are probably quite familiar with, particularly in the winter years. And we know that almost all children will go on to make a full recovery. We know that the treatments needed for bronchiolitis are mainly around breathing and feeding. So some patients may need oxygen support, and obviously they will need admission. If you're in the hospital setting, there are other things. So there's a role for different types of respiratory support, and that's things like providing high flow support with nasal cannula for oxygen. And also we know that there's a small proportion of patients which will go on to need more intensive care therapy, and that will be done in the paediatric intensive care unit. We know that feeding support is the other area for babies with bronchiolitis and that they benefit from having little and often. And I think it's useful to think about this in the context of keeping patients at home, because many patients will be able to stay hydrated by feeding just more frequently with smaller volumes. Those that aren't able to manage that often do require admission for support with things like NG tubes, and that's always our first line of treatment if support with feeding is needed. And then a few or a smaller proportion will require IV fluids to maintain their hydration status. But the mainstay of treatment with bronchiolitis is time and good safety net advice, and that's what we know that Healthier Together can provide. I think bronchiolitis has been around forever, and as such, people are desperate to find a treatment that really works and ends the illness earlier, because anyone who's had a baby with bronchiolitis knows that that week that they're unwell is a really long time. Unfortunately, we know that many things don't work. So things like bronchodilators, so salbutamol, do not make any difference in bronchiolitis. Steroids do not do anything to support bronchiolitis, and in fact, the side effects of those in the under one group are a very good reason to not give them. Antibiotics will not work because this is predominantly caused by a viral infection, most typically RSV, and then other things such as hypertonic saline, and you name it, it's been tried, but it doesn't work, and time is the most important thing. And I think that's probably the most important thing for parents to understand as well. And that's where Healthy Together can really be useful for you. We know that actually there's some exciting stuff coming. There is a possibility of preventing bronchiolitis now. We've had a program for high-risk babies having the monoclonal antibody to protect them from RSV for quite a few years now, but they have very strict criteria, and they're predominantly those ex-premature babies who are in home oxygen. There are a few other criteria, but they're the main ones. And for those babies, they have to have that injection once a month, and it's not perfect, but would hopefully prevent more severe disease. But also, excitingly, very recently, there's been the introduction of vaccine during pregnancy, and this is probably something that can be really maybe very beneficial moving forward if we can get good uptake of the vaccination during pregnancy. Mums are given the vaccine at about 28 weeks, and this protects those babies for that first 6 months of life when they're at the most risk of infection and severe complications of the infection. But the thing that people always worry about is, but what if it's not bronchiolitis? Because there are many things that people worry about can look a bit like bronchiolitis. So how do we know when it's not bronchiolitis? So if we go back to our original case study, often the key comes from the history. And what I'm going to present now is just a few cases where the initial history sounds like bronchiolitis, but when there's more in-depth history taking, you'll see that there are differentials. And I don't tell you this to scare people, but I tell you it to share some of the experience that we've had and I've had over the years as a consultant to know when does it not fit that pattern, because the majority of patients that we see will present with the same history that I had presented in the earlier case. But a case we had recently was slightly different. So this was a child who presented with 3 days of a runny nose and a cough. But when you actually spoke to mum, they were always seemed to be breathing fast. And in fact, what she'd noticed was that they always seemed to struggle with feeding. And this today, the day that she presented, was no different, but perhaps more pronounced. But what she talks about when you speak to her in a bit more detail is that this baby was breathless when they were feeding, and not just for the past 3 days when they'd had a congested nose, but for much longer and for many, much of the time that they'd been born. And she also commented that they were a really noisy breather. So this case is slightly different, and the reason for that is that they presented on a couple of occasions to the emergency department, and I think that's why it's worth thinking about, because in a busy department, you see a breathless baby, it's bronchiolitis season, it's much easier to think that this is bronchiolitis and maybe with a degree of floppy larynx or laryngomalacia. But actually, when you talk to mum, the clues were there. Then they actually represented having been seen with worsening respiratory distress and really quite marked recession. And the history had been that over the preceding 2 to 3 months, they'd become much more breathless with feeds and were now really struggling. When you listen to a baby's chest who's got bronchiolitis, you classically hear crackles and wheeze. And when this baby was examined, they didn't have any wheeze. They actually went on to have a chest x-ray, and that's what shows here, is that they had a very big heart. And in fact, this was a baby with a congenital cardiac defect, which was presenting with breathlessness. The second case that I present is another one that presented to our emergency department a few years ago. They again had a very similar case. They'd had 3 days of runny nose and cough at the time of presentation and a couple of days of breathing faster, and they'd had poor feeding. But what mum said was that they'd had multiple episodes of bronchiolitis and they were only a few months of age. And whilst we know you can get different viruses and you can get bronchiolitis more than once, mum sort of mentioned that she really seemed to think that this baby was never getting better and never completely getting rid of their bronchiolitis. And they were perhaps having periods where they were slightly better, but they were really struggling and they were struggling to feed. And as a result, they were having poor weight gain. What was also interesting was that they were a twin. and mum gave us a very clear history that this twin was not like the other twin. And the key thing here was that mum was saying that this twin was not thriving, that they weren't gaining weight, and were never completely getting over their bronchiolitis. And if you look at the stars on their weight chart, this shows a really nice example of falling off the centiles, and corroborates what mum was saying with their failure to gain weight. Now, this wasn't a baby who was just being unwell and gaining weight in between times. This was a baby that was never really getting back to baseline. And unfortunately, they were found to have a problem with their immune system when they did have some bloods done, and they were found to have a form of severe combined immunodeficiency. And it's just worth mentioning that the red flags for immunodeficiency include the failure to gain weight and grow normally. And the ones I put in red are the ones that were found to be the most important. And I think it's important to think about those in the context of bronchiolitis. So the differential for bronchiolitis, and that I've shown in the past in the previous 3 cases, is to think about cardiac disease. And the keys and the clues that you can get for that are that there's generally a longer duration of symptoms. And when you really drill down on the history, you'll find that they haven't always been snotty when they've been struggling with their breathing, and that the problem has been predominantly with being breathless when feeding. When you examine them, you may also find different signs. You may find that they've got a murmur, but not always. You may be able to feel a liver edge, and you may struggle to feel femoral pulses. And you may notice that they're one of the few babies that's not snotty. In this context of the problem, the ones who have a problem with their immune system, you might find that in the history, they've not got a typical course. So they're not recovering in between illnesses. And that because of that, they are also faltering in their growth. There may be other features when you really ask as well, and there may, but not always, be a family history. When you examine them, they may look different, they may look scrawny, they may have problems with their skin, and particularly when they are falling off their centiles, that's particularly a time to be concerned. There are also more rarer respiratory diagnoses, and again, they often present with persistent one-sided signs, or they may not have that typical classical history that we hear of bronchiolitis, and so that they may need further investigation. However, the good news is that our initial baby did just have bronchiolitis and was able to be safely discharged with some safety net advice. And when you look at the website, you'll find that for every condition that we cover today, and for many others, there are these traffic light signs that I have talked about. And you can also SMS share these with parents, and that's what's really helpful, that you're able to go, you can able to directly send this page to a parent's mobile. And it means that you can go through it with them if you want, but also that they've got ready access to it. And what the hope will be is that if you send them the bronchiolitis page, is that when they're reading about bronchiolitis and diligently studying, they may also look at some of the other pages and have a look around the website and think about what other things they can read about. So the next thing that we're going to come about is we're going to think about is diarrhea and vomiting. So again, I'm sure many of you have been afflicted in some way or another, even yourselves or with children, particularly in this time, which is the kind of springtime, which is classic outbreak time for diarrhea and vomiting. So I guess it's worth thinking about what are some of the red flags for diarrhea and vomiting. And I think it's like all these things, the commonest reason that children have diarrhea and vomiting is because of a viral gastroenteritis bug. Even in the children where this seems to be persisting for a bit longer than we would like, the answer is still that they've often got just a particularly persistent form of viral gastroenteritis. However, of course, with all these things, there are ways that we can be caught out. And I think this is often where some anxiety in professionals exists. And this is hopefully where we can help with the professionals pathway. Probably in thinking about the under 1 age group, the thing that we want to make sure that we don't miss is the alternative diagnosis. And those ones are things like where the baby is actually systemically unwell. Now, of course, you can become systemically unwell through dehydration with gastroenteritis, but if you've got another form of infection, you may also become systemically unwell and may require different treatment to gastroenteritis. So thinking about alternative diagnoses, thinking about babies who are febrile and who are only vomiting should always raise the question about whether or not there could be an alternative diagnosis. Bilious vomiting, and this can be really tricky to drill down with for parents, because I think parents often use the term bile, but what we mean when we mean bilious vomiting is actually that really bright green colour, which looks very different to typical baby vomit, even in the context of a baby that's been vomiting a long time. Bilious vomiting is the kind of the green colour in this slide, and that is obviously a red flag and may suggest that there's something more surgical going on. In little babies, a very high fever can also be a worrying sign in the context of being unwell, and might make you think about whether or not there's something else going on, such as systemic infection, one of the more severe bacterial infections, or a urinary tract infection. In our professionals pathway, there are a few things that it's just worth drawing your attention to. The first is thinking about whether or not there's any role for testing for different viral gastroenteritis bugs. Historically, there have been rapid tests for rota and adenovirus, but these actually have no evidence to, and the lab in Newcastle have recently stopped doing the rapid test for rotavirus and adenovirus, which was a test that could easily be requested because it was no more sensitive or specific than flipping a coin, and actually didn't change clinical outcome. So that stopped being done. The only time when we find that it's really beneficial to look for a specific virus is if public health have asked for it. So if they're looking for an outbreak, and that's often associated with things like norovirus in the winter, and that's more to think about outbreak control or to try and pinpoint things. The rest of the time, viral gastroenteritis is a self-limiting illness, and knowing which virus it is, although academically very interesting, is not going to change management. It isn't something that we should be routinely doing. And I think most parents understand that, but it's useful to have that kind of written down, and that's what it does say, so that people understand the need. Increasingly, we know that if you're not clinically dehydrated, you can safely be managed at home. So what this pathway helps you work out is what are those parameters to look for to support making that diagnosis of whether or not little ones are dehydrated. In this under 1 age group, I think we're much more cautious because we know that they've got less reserve than the bigger children, who we know will cope much better, or even those of us who are adults who coped with vomiting and cope better because we've got that bit more reserve. I would have a much lower threshold for a very small baby, both for the fact that they may present slightly differently and you want to be confident in your diagnosis, but also because actually they probably tolerate losing fluid less well. So here you can see that talks you through what those which risk group you can put them in, and agree an action with the parents. And of course, because we want to be able to share the decision making and the safety netting with parents, we can provide them with the safety netting from Healthier Together. The majority of patients will fall into the green category. Some will fall into the amber, and it's easy to be able to share that. And the few that fall into the red category, we would obviously be sending them to a further place for further assessment rather than simply discharging them. But it's useful for parents to be able to see that. And we've had countless examples of parents who've been able to work through the traffic lights themselves so that they can be reassured that they can safely manage their child at home. We also generally, when you're on the Healthier Together page, you'll find that the red category comes up first. So actually it's designed to be easy for parents so that they can look at the serious signs and then work their way down. So from vomiting and diarrhea, it leads us onto a kind of an area which links very nicely into vomiting, but thinking more about some of the chronic conditions. So feeding is probably one of the biggest things that a baby under 1 has to do, isn't it? And it's probably, again, some of the things that we get the most questions about. I think it's important to think about things in context with each other. So I'm going to talk a bit about calcium and protein, a bit about gastroesophageal reflux. And one of the things that is present throughout that is weight, because we know that that's a really helpful indicator for babies as to whether or not they're thriving. And if they're thriving, that's a really supportive sign that they're generally well and managing, and means that we can often be a bit more relaxed. I also put this up because I think there's very often, and I have this conversation with parents a lot in clinic, there's often an overlap between cow's milk protein allergy and gastroesophageal reflux. And the differentiation is clinical, but can be really tricky. And sometimes that can be frustrating for families and for professionals trying to work out which is contributing the most to their baby's presentation. And there's not always a straightforward answer, but we'll take you through some of the pathways here to try and just help you see how we've tried to explain things. So the first baby that we're going to think about is a bottle-fed baby who mum describes as a really unsettled baby. She says that the baby's got diarrhea, which is a term which is used a lot and means different things to different people. But when you speak to mum, she says that the baby's got quite mucousy stools, sometimes some blood in the stool, is also quite a vomity baby and is quite a rashy baby. Mum says her previous children had really good skin, but this child's got quite dry skin and frequently gets non-specific rashes. So from if you just put in the chat, who would think that this was a cow's milk protein allergy? Who would think this was a refluxy baby? Any thoughts? You can pop them in the chat and I'll give you, yeah. Excellent. Everyone's in agreement. So yeah, I agree. I think this little one's got features very specific to a cow's milk protein allergy. And this is something that we see a lot. We see much more now than we did previously. And they can be really challenging babies just to manage at home because they can be really quite unsettled, and that feeling of kind of having mucousy stools is presumably quite giving babies quite a lot of cramps. The red flags for cow's milk protein allergy are important as well, because actually this is something that can be managed with patience and time, but it's important to think about what are the red flags that you would want to refer on more promptly. So cow's milk protein allergy is a non-IgE mediated and is a delayed response. If a baby is having an immediate reaction, much more suggestive of an IgE mediated allergy or anaphylaxis, then that's something that should be referred directly in and not something that should be managed at home. It's far less common than cow's milk protein allergy, but does happen. Faltering growth is another sign, and it's a red flag in the sense that it means we need to think about it a bit more. The diagnosis is often actually cow's milk protein, but that doesn't mean that we can ignore the faltering growth. Ongoing blood in the stool despite a change of milk, and we'll come on to that in a moment, is a red flag in the sense that it just needs more consideration. Often these babies do make a very good resolution, and we'll talk about that in a moment. But if they've got ongoing symptoms, thinking about whether or not this is the diagnosis is important. Babies with severe atopic dermatitis are also important to consider, both in the context of are they getting all the treatment they need, and again, is there another diagnosis? And then much rarer and much further down the list is something called FPIES, but these babies tend to present with profuse vomiting with collapse and actually often look like they have been a septic baby, but it is certainly something that would raise a red flag. But I think the majority of people would be concerned if they had a baby that collapsed. So I think it's absolutely a red flag, but hopefully it's a fairly obvious one. So our professional pathway, sorry, this doesn't come out very well, is really helpful, and it takes you down two pathways, and it takes you down have they got IgE mediated, which essentially means that they need to be referred in, or have they got non-IgE mediated? And then within the non-IgE mediated, have they got mild to moderate symptoms, or are they at the more severe end? It then talks about excluding the cow's milk protein, and that means for formula-fed babies, that means a change of formula. There are different formulas depending on, I think, often what your practice, if you're in primary care, opts to prescribe. And there are two types. There's your extensive highly hydrolyzed and there is your amino acid formula. And there are many versions of each one depending on which brand you use. For breastfed babies, the mums, unfortunately, they have to have dairy completely out of their diet, and they will need support from a dietitian to make sure that they are getting enough calcium in their diet, and may need vitamin D or calcium support for that. The key to the diagnosis is about excluding cow's milk protein and then seeing if the symptoms resolve. What we see a lot of, and I completely understand how this happens, is frequent changes of milk. And you'll often see a baby who's been on SMA, then Cow and Gate, then Aptamil, or various different types of formula, but they're essentially all the same because they all have cow's milk in. When you switch them to either, depending on which arm you're in, an extensively hydrolyzed or an amino acid formula, it's really important to explain to the family that this takes time to work. And we usually say that it's going to take 4 to 6 weeks. In reality, parents often see a response much quicker than that. But the guideline you see says you do have to trial it for 4 weeks. The hard bit about the guideline is that it does then say that you should re-challenge. I'm a bit of a wuss. I often don't re-challenge at that stage, partly because if it's made such a convincing response, I think it's really hard to get parents to try again. If there's any diagnostic uncertainty, then you absolutely should re-challenge. And by the book, you should re-challenge. But it always feels a bit mean when they've had a really positive response to a milk change to then try and re-change it. However, some families are quite keen to do that just to prove it. In our guideline, it gives you it tells you about the different types, and it tells you again in the green, amber, and red columns as to which one you should try for. At the bottom, we've listed some commonly used examples of those types of either extensively hydrolyzed or amino acid milks. And I personally find this really helpful because I can never remember them. And I think you may have experience as to which one you use in primary care, but I think it's always good to have an example so that you know what you're talking about. You have to be really careful as some of the names are really similar, even though they're slightly different milks. So I always look it up. Healthier Together provides information, not just for professionals, but it also provides information for parents. And on that site, you can see that there's information about what is the diagnosis, and also about reintroducing milk. And that's something that's really important. There are also some videos that parents can watch, and I think it's a really good resource so that you can direct parents towards that so that they understand it. And then it's something for them to look at. But I think the key piece of information that I would say is the important thing to know is the time it takes to see resolution. And then also about the reintroduction of milk through weaning and in a controlled manner. And you'll find that there's a link on that page to the milk ladder as well. What we've mentioned that often coexists with cow's milk protein is gastroesophageal reflux. And I often think that it's because the two things coexist, this is the situation, you may find that you get partial resolution of symptoms, particularly if they're a very vomity baby. And I think it's really important to be clear with families about what you think you're going to achieve. So when we're thinking about cow's milk protein, if they've got a real mix of symptoms, probably the symptoms you're going to see resolution for cow's milk protein allergy are the diarrhea, hopefully some of a degree of the unsettledness, some of the vomiting, and some of the skin changes. If they've got coexisting gastroesophageal reflux, they may still be unsettled and they may still be a vomity baby. And that's when making the decision as to whether or not they warrant treatment for reflux or whether or not they need further escalation up the milk in the milk change is a clinical decision. And again, that's why it's really helpful if, where at all possible, there's one new professional involved with this family, because I think otherwise it can be quite frustrating when people do things slightly differently. None of it is wrong, but I think it's challenging for parents and families. So gastroesophageal reflux, again, is so common, and we know that often it is really common in children sort of less than 4 months, and then by the age of about 6 months, things are starting to get better. These are babies that are typically have effortless vomiting, but of course, vomiting can be, as we've already alluded to, a different a symptom of many things. So when we think about reflux, it's also important to think about what are those red flags that would make us more concerned. Now, if you look at the bottom one to start with, actually, most babies who are refluxy would have been a vomity baby since birth. So children who haven't been vomiting and who start vomiting at 6 months, that's slightly more unusual and certainly warrants thinking about. Then obviously there are other things which have a more of a neurological presentation. So if a child has got a rapidly increasing head circumference or a bulging fontanelle and they're vomiting, then that's a really quite serious red flag and is something that should be referred in immediately. Children who are unwell or have a high fever and altered responsiveness associated with vomiting, again, is something that should be seen. And yet there again is the faltering growth, and that's something that we see as a generic red flag, really, because it suggests that all is not well. Then the other kind of vomiting red flags are again that bilious vomit, that green colour, very forceful or projectile vomiting babies. Thinking about particularly in those early weeks or couple of months and thinking about pyloric stenosis. Remembering that those babies will generally be hungry and having faltering growth, but there have definitely been examples where parents have been managing to feed these babies so that they haven't fallen off their perch, but they've still got pyloric stenosis. So asking parents specifically about whether or not they think that their baby could, when they vomit, it would go across the room is quite a helpful pointer to think about whether or not they've got forceful vomiting. Gastroesophageal reflux does not always warrant treatment, and this is one of our pathways. If the baby is thriving, they're not too unsettled, and actually the parents are dealing quite well with the amount of washing that's resulting from them being a refluxy baby, then time is the best treatment for gastroesophageal reflux, as it will get better, both because as they get older, it gets better, and as they get more upright, it gets better, and also as they eat more solid food and not just milk, it gets better. There are treatment options, and I think the guidance within primary care and within us is to think about a thickener, and the thickeners that are recommended are things like Gaviscon and Carabel. The danger and the caveat to that is that these can often thicken fluids the whole way down, and this is what I say to parents, and means that they end up being quite constipated. So it's always a balancing act between how much of a problem is the vomiting versus how much of a benefit they get from those thickeners. Things like omeprazole and lansoprazole can be useful for a short time, and particularly if they are very unsettled, but it will mainly treat the associated esophagitis rather than stopping the vomiting. And again, I think this is about being clear with parents what you can achieve rather than promising to get the babies vomiting free. And then probably, again, a really common presentation, and I'm sure the health visitors amongst the audience will have a real experience of this, is generally being unsettled babies. And I think this is a really tricky area, and I think it's one of the guidelines that I really like on Healthier Together, because I think it provides professionals with just a little bit of objective evidence to try and support people in making a decision as to whether or not how concerned we need to be. I'm just going to draw your attention to the red flags, because I think, as we all know, babies can be incredibly unsettled, and everyone has a different threshold for what they consider unsettled. We also know that some babies, like some adults, are very different, and some prefer being upright, and maybe those who've got a degree of reflux are more likely to be like that. So thinking about some of the red flags that we know for an unsettled baby is really important. And again, they have a significant overlap with some of the ones we've already discussed, but also thinking about not just the physical signs of what else could be medically wrong with the baby, or is this just normal, but also thinking about that wider family and thinking about things like, is this reportedly a very unsettled baby, because are there associated kind of parental postnatal depression issues? Are there safeguarding concerns? Babies that cry a lot are obviously likely to have knock-on effects. It's exhausting when you've got a small baby. It's very exhausting when they are very unsettled, and it's just really drawing attention to that. And we certainly direct people towards the ICON website on Healthier Together as well. The other thing we know is that we've got a nice pathway here for Healthier Together, which talks you through the unsettled baby. Some of it takes you through whether or not there is a medical concern, and so that's things like thinking about, is this someone who's suffering from calcium or protein allergy? is this a baby who's got gastroesophageal reflux, or is this actually normal crying? And the majority of babies, when you look through this guideline, you'll see that the majority of babies probably fall into the normal crying section. And actually, I think this is one of the things that's really supportive, because having that transparency of showing the parents and the professionals both pages, we can support parents to look at that. And this flowchart takes you through those diagnoses, through what you need to exclude, and then links to the relevant page on the website. And that's the normal crying section. So the other thing that we've got a little bit, we get asked about quite a lot, and we've got some information available on the Healthier Together website, is staying healthy. So for the under ones, the predominant area that we probably get asked about is vaccination. And I think this is something that all of us as healthcare professionals worry about the uptake of. Increasingly, we're seeing a downward trend in people uptaking vaccines, and I think it's really important to be able to guide parents through that support about their decision making and provide them with relevant, appropriate information. We have a whole section on childhood vaccinations, and predominantly this links out to the NHS website, so it's a trusted website that you can you can direct parents towards, and then you can share their information with them. It also enables us to put, for the older children, relevant seasonal vaccinations on there. So when the flu vaccination was coming into play, we can also direct you towards that, direct parents towards that. And this provides information about vaccinations. And what we hope Healthier Together provides is a reliable central resource where parents can find trusted information. Because of the way we work, we've been able to raise awareness quite quickly when there have been outbreaks like things like the streptococcal throat infection, outbreaks of measles. We can put information on Healthy Together and disseminate it very quickly. So we hope that that's an area where we can really support people in the community to share information from a trusted site. That's actually all I was going to say on the things that I suggested at the start. I'm quite happy to take any questions either in the chat or in person about any of the stuff that I've covered, or anything that you want, really. So take it away. Any questions?
Thanks, Alex. Yeah, if anybody wants to ask a question, you can type them in the chat or put your hand up. It'd be great to get some questions and some feedback or any comments around the session. Anything you would like to kind of us to cover in future sessions as we move and develop other sessions moving forward across the year.
And also anything that you haven't found. So if you've used Healthier Together, anything that you have wanted to be on Healthier Together that hasn't been there, if that makes sense. So any topics that we think are missing, because we're moving towards a new format, so there'll be an opportunity to think about kind of additional topics as well. Any questions?
Any questions? This is where everybody goes quiet.
So everyone's gone for their coffee. That's fine if there are no questions. I'm happy to.
Oh, very helpful. We've just got, thank you. It's great. Yeah, and just to alert people that Healthier Together will look slightly different from the 1st of April, but we will be doing some comms around that. We're actually moving to a hub and spoke website, working with other ICBs across the country. As you notice, it is going to be a much more modern look and feel to the website. So we hope that the work that's been done around it, and as it moves to that more modern view, you'll be able to you'll like it even better. Just some examples of some positive work that's been happening. We've Newcastle 0 to 19 service has actually been using it on their for single point of contact. They've actually been, when a parent's ringing, for advice, they're actually signposting parents to Healthier Together using the SMS share, which we've seen a significant rise in the website. So just any kind of useful tips for people using the website or within 0 to 19 services, it is there to kind of to be that mechanism for parents to go to if they're waiting for an appointment and you want to share some information with them. So just ways that you can use it in different ways as well. Anybody else got anything? I think we've got everybody gone quiet. So, oh, This has been very informative. Can we get a copy of the slides? And is there any handouts for parents regarding the difference in CPMA and other issues? We don't particularly have any handouts, but moving forward, the website you will be able to, there'll be printer friendly pages. So it may be that if you wanted to kind of print any information out that you want to give to parents, you could actually utilize the page, or you could actually give them the link, send the SMS link share page to them. That's what other areas are doing. I know obviously that doesn't help if a parent hasn't got a mobile phone or digital, but you could print that. They are going to be printer friendly from moving forward. And maybe info on newborn baby spots on faces and rashes. So that's another thing we can add to our list, rashes.
Yeah, I think a whole session on skin would probably be quite helpful, because that is probably something that we get a lot of questions about.
No, we'll take them notes down, and we can arrange some over the coming months of new set of different topics. Birthmarks. So I guess we could cover that in.
We could definitely do that. I love a birthmark.
Skin rashes and marks, I guess, couldn't you? You could incorporate that together.
And actually, I think just with regards to the comment about birthmarks, that's a really good suggestion, because also I think thinking about referral pathways for that is quite helpful.
Yeah. Fabulous. We've got a hand up.
I can't see.
It is. I know it's hard to see when you've got the.
I can't get rid of the slide. I'm really sorry.
Stacey.
Hello, Alex. I was just going to ask, we see a lot of babies that would do the 9 to 12 month reviews.
Yeah.
And they've been started on specialist formulas for cow's milk protein allergy, and then they haven't really moved on from it. And would you suggest that when they're ready to wean, well, sorry, I've lost my train of thought. I was just thinking, how do you move them on from it? To other cow's milk alternatives, like what would be suitable?
Yeah, so that's a really good question. So we recommend that all children who are on a specialised milk should be referred into the dietitians, into a community-based service, because actually that's exactly what they should support with. What you sometimes find is that, and I've seen this before, is that actually parents have just slightly got the wrong end of the stick, and they're actually tolerating milk-based products in their diet. So when that's the case, I often take a pragmatic approach and use the milk ladder to kind of try and reintroduce slowly. And if they don't get recurrence of symptoms, then you can safely do that.
Yeah, sorry, that was my question. I was going to say, when they get to 6 months or whenever they're ready to wean, can you start the milk ladder from then?
Yeah, so I think if they haven't been a severely affected one, then I would definitely try. If they've been really severely affected, and I think we can all probably think of examples where they've had a really awful time, I would wait and get the dietitian's input, because they can support with the alternatives. And it might be that actually they stay dairy free until 1 year. The majority of babies, I think, are okay. But some of them could can wait until a year, but I would do that with dietetic support. But the milk ladder is actually on Healthier Together as well, so you can give that to parents. It's got some examples of what the different things are.
Oh, that was really useful, and I have been sharing that a lot lately. And just so usually we'll see some of them that haven't really been referred to a dietitian, and then their weight's quite high because they've been having lots of milk and foods. So what other, is it still from one that they wouldn't ever go on soya milk? I know some babies get to one and they don't really tend to drink a lot of formula milk anymore, but what other alternatives would you suggest?
So there's things like coconut and almond, and all those are all okay. And I think we do tend to still avoid soya, but those the other alternatives are generally kind of what they'll take. You can also use the ongoing specialized ones, but I think it's a minority who really won't tolerate dairy once you get to a year.
Yeah, that's
in my experience. But
for clarifying that.
Yeah. Is that
Thanks
okay?
very much. Yeah, brilliant, thanks.
Laura, you're muted, so if you're speaking, I can't hear you.
I am speaking, sorry.
I could just feel it.
I know, that's the great thing. Why do we still do this? How many years on using Teams? If anybody hasn't got any further questions, we will conclude the session and end it now. Thank you to everybody for coming, and we look forward to seeing you on further sessions. This probably will go up within the next week or so, but I will email everybody with the link to where it's hosted on Healthier Together website. So we do put all of our learning sessions on there, and there's some from previous sessions that you may find interesting. Thank you for attending.
Thanks, Laura. Bye.
Thanks, bye.